This conference will now be recorded.
Good morning, everyone. Today we'll be discussing the topic surgery in pregnancy. Okay, what are the physiological changes happening in pregnancy? What are the surgical pathologies happening in pregnancy? And what care you should take? And how to manage the surgical conditions? Okay. First of all, what are the various physiological changes? Each system-wise we'll see. What changes will happen with respect to the cardiovascular system? What changes will happen in the respiratory system of a pregnant patient, and how does it impact the surgical outcomes? Okay. What are the physiological changes happen with respect to the gastrointestinal tract? Okay. In all pregnants, there will be delayed activation of all the smooth muscles. Okay. Smooth muscles, whether it be of the urinary system or gastrointestinal system or hepatobiliary system, all the smooth muscles, the contractility will decrease, thereby gastric emptying time, okay, gastric emptying time will be decreased, reflex will be increased, okay, small bowel motility and large bowel motility will be decreased. What will what will decrease in large bowel motility cause? Constipation, okay, colonic motility is decreased, portal venous pressure is increased, changes with respect to the hepatobiliary system, okay, here also there will be thick bile because of decreased emptying of the gallbladder, because of the decreased bile flow. Because of the decreased bile flow, bile will be thick, causing increased precipitation and stone formation. With respect to the cardiovascular system, in all pregnants, as the gestational age grows, blood volume will increase, hematocrit will increase, plasma volume will increase, okay, and cardiac output will also be increased. What effects are there on the cardiovascular system by the gravid uterus? We know that as the gestational age increases from first trimester to second and third trimester, the gravid uterus outgrows the pelvis, okay. Within the first trimester or mostly up to 10 weeks, the gravid uterus is a pelvic organ. Gravid uterus is a pelvic organ in the first 10 weeks, but after 10 weeks the uterus will grow above the pelvic brim and will become an abdominal organ. And as the uterus grows even to a much farther gestational age, into the third trimester, okay, it will cause compression on the abdominal structures, mainly the abdominal vasculature, on the inferior vena cava on the right side and aorta is on the left side. So which is more compressible? Is it the IVC or aorta which is more compressible? Which is more compressible? IVC is more compressible. So the compressive effects of the gravid uterus are more on the IVC. So if a pregnant patient sleeps on her right side, it will compress the IVC and cause decreased venous return. This will also bring hypotension. So the pregnant full-term pregnant patient, whether it may be in the operation room or in the general regular day-to-day activities, she should ask to lie down on the left side, okay. When if she lies down on the left side, the abdominal compression pressure on the inferior vena cava will reduce and the hemodynamic stability will be attained. These are the physiological changes in hematological system, that is plasma volume, RBC mass, white cell mass, coagulation, coagulating factors, all will be increased during pregnancy. Because of increase in the coagulation factors, thrombosis is more common in pregnancy, okay. Changes in the respiratory system. What changes will occur during pregnancy? Because of the increase in pelvic and abdominal contents, because the abdomen and pelvis is occupied by the gravid uterus, the diaphragm is pushed up, the diaphragm is pushed up and all the lung volumes will decrease, okay. How does the pregnant compensate for the decrease in lung volumes? Because of decrease in the diaphragmatic height, anterior posterior diameter of the rib cage increases and there will be tachypnea or increased respiratory rate. Because of increased respiratory rate, the pregnant mother is able to have enough oxygen and also wash out carbon dioxide. The PCO2 in pregnancy is much less compared to normal adults. How is this going to help the mother or the fetus? Because the fetus is depending on the placenta for oxygen diffusion. If the mother is having less PCO2, then CO2 can diffuse from the fetus to the mother. If CO2 is high in the mother, then CO2 will not diffuse from fetus to the mother. Okay, this will cause CO2 retention in the fetus. With respect to the renal system, because blood volume, as previously have seen in the hematological system, the plasma volume is increased, cardiac output is increased, so GFR will also be increased, and because of increased GFR, more creatinine will be washed out. Okay, serum creatinine levels in a pregnant are much less compared to normal individuals, because creatinine is more washed out because of the presence of increased plasma volume or blood volume. GFR is increased, and as a result more creatinine is washed out. Okay, physiological changes of endocrine system, cortisol levels are increased, T4 is increased, and as we know that there is an inverse feedback effect of T4 on TSH. TSH will be decreased. Okay, this increased T4 is very much essential for the organogenesis and better fetal well-being. Okay, T4 values should be regulated well. Hypothyroidism should not be tolerated and should be promptly treated. Okay, coming to imaging in pregnant patients. What sort of imaging should be done? What are the adverse effects of regular imaging? You can't use regular imaging like X-rays and CT scans, which are more sensitive. X-rays and CT scans are even more sensitive compared to ultrasonography and in some instances MRI. But in pregnant mothers, because the fetus can be exposed to the teratogenic effects of this ionizing radiation, all investigations having ionizing radiations should be avoided, especially in the first trimester. Okay, what happens in the first trimester? Organogenesis will happen. Organogenesis will happen in the first trimester or first 14 weeks. So during this period, ionizing radiation should be strictly contraindicated or withheld. What is the acceptable dose of ionizing radiation in pregnancy? It is 5 radons. The conversion rate of grays and radons. What is the conversion rate between grays and radons? 1 gray is equal to 100 radons. Okay. What is the effect of ionizing radiation on pregnancy? It will cause teratogenicity and carcinogenic effects. It may cause leukemias. It may cause leukemias, or it may cause congenital abnormalities. The organogenesis might not happen properly. Okay. This slide shows the radiation dose of various investigative imaging techniques. Okay. This slide shows the radiation dose of various investigative imaging techniques. X-rays of long bones and cervical spine requires very less radiation dose because there is less soft tissue cover, and if you want to image the bones, because they are radio opaque, even the slightest X-ray radiation dose can give you clinically sufficient image contrast. Okay, but when you expect imaging of the thorax and abdomen, because there are many structures and many soft tissues, whether you want to x-ray the soft tissues or the spine, it requires more radiation compared to the c-spine and long bones. Coming to the CT scan, as you know, CT scan takes several sections of imaging and hence has more and hence needs more radiation dose. Among the CT scans, what type of scans will have the high radiation dose? 34 milligrays is the radiation dose in CT angiography. Okay, and what is angiography? injecting contrast into the vessels and imaging the vessels or the vascular system, the arteries and veins. Okay, CT arteriography and venography, or CT angiography. Okay, this requires more the highest radiation dose. Okay, so CT scans are avoided, and ultrasonography and MRI are the investigations of choice during pregnancy. What are the investigations of choice in pregnancy? Non-invasive, non-ionizing radiations. Non-invasive, non-ionizing radiations are the investigations of choice during pregnancy. What are they? Ultrasonography and MRI. What are the implications of anesthesia in pregnancy? What is the difference of the anesthetic drug of choice in pregnants and in normal adults? Because of the teratogenic side effects of anesthetics, we make a better choice of those drugs which have less teratogenic side effects. Okay. And also, aspiration is much higher. Aspiration is much higher in pregnant mothers because of increased reflex. We have early seen the physiological changes in the gastrointestinal system. Reflex is very much common, present almost in 80% of pregnancy. So this might cause aspiration during general anesthesia and intubation. Also, intubation is also tough in pregnancy than compared to pre-pregnancy state because of short neck and swelling of the neck during pregnancy. The airway is narrowed, and intubation is little difficult. As we know that anesthesia will paralyze the respiratory muscles, and the pregnant mother depends on ambulation or ambu bag or mechanical ventilation because of the risks of aspiration also. Even mild changes in the respiratory coefficients will cause a deleterious and bad effect on the fetal growth. Even before the mother can show any symptoms or signs of decreased PO2 delivery or ventilation, the fetus will show deleterious effects. Okay. How do you treat hypotension? How do you treat hypotension in pregnancy? How can you treat hypotension? By elevation of the legs, okay, and left side tilting. Tilting the patient to the left side will decrease the compressive factors of gravid uterus on the IVC, and elevating the lower end or limbs will cause increased venous return. This can help to contradict or correct the hypotension because of blood loss or any other condition or any other surgical condition during pregnancy. Okay. Maneuvers such as fluid bolus, Trendelenburg position, left lateral positions, compression stockings, and leg elevation have an impact on increasing the uterine blood flow also. Because of this, the fetal well-being will also be there. And in case these maneuvers could not maintain sufficient blood pressure, then you use pure alpha agonists. What are pure alpha agonists? Give some examples. Phenylephrine and metaraminol. These are the drugs of choice to maintain blood pressure or correct hypotension in pregnant mothers if the blood pressure is not controlled by non-pharmacological methods. Okay. Coming to the timing of surgery. If in case an elective surgery should be done in pregnancy, which is the best trimester? Because of organogenesis during the first trimester and increased preterm deliveries or spontaneous induction of abortions or labor during the third trimester, second trimester is relatively good, or second trimester has less adverse effects compared to first trimester and third trimester. Management of pain. How do you manage pain during pregnancy? What are the drugs of choice? Usually, NSAIDs are the drugs of choice in adults for effective analgesia. But during pregnancy, NSAIDs cause increased premature labor. It causes fatal renal injury and premature closure of PDA or DA, ductus arteriosus. Okay, PDA is patent ductus arteriosus. Okay, what does NSAIDs cause? NSAIDs will cause closure of the ductus arteriosus. If you use NSAIDs on pregnant mothers, they will act on the fetus and cause closure of ductus arteriosus in the intrauterine life itself. So NSAIDs should be strictly contraindicated as analgesic medicines. Then what are the analgesics of choice? What are the analgesics of choice in pregnancy? The first analgesic of choice is your simple paracetamol or acetaminophen. The first analgesic of choice during pregnancy is acetaminophen, and the second drug of choice are opioids. But opioids can be used in the short term but should not be used in the long term, because dependency and tolerance will make the mother habituated to increased opioid doses, and these increased opioid doses can cause respiratory depression in the fetus. There is a technique in analgesia called patient controlled analgesia, PCA. Patient controlled analgesia means whenever you are using opioids, especially in pregnancy and other conditions where you want to titrate the dose to the most optimum dosage, then we use patient controlled analgesia to decrease the amount of opioid exposure. So what are the most common surgical conditions in a pregnant mother? As usual, in depending upon the age of the mother, the conditions which an adult can have during that period also are common during any mother of the corresponding age. Okay, acute appendicitis is one most common emergency. Most common does not mean that it occurs more in pregnants than in non-pregnants. It does not occur more in pregnants, but among the acute surgical conditions in pregnants, acute appendicitis is most common, followed by acute cholecystitis, and small bowel obstruction is the third most common cause of surgical intervention. Okay, and how do you prevent preterm labor during various conditions of surgical pathologies, especially if a surgical condition or a intraperitoneal condition like appendicitis or cholecystitis and peritoneal irritation? If there is some peritoneal irritation or peritonitis, that will result in preterm labor. Okay, especially if this pathology occurs during the third trimester, then you have to take some measures to prevent preterm labor and prolong the labor to full gestational age. How can you prevent preterm labor? You can use tocolytics. What are tocolytics? Tocolytics are uterine relaxants. Tocolytics are uterine relaxants. You can use uterine relaxants to prevent preterm labor. The risk of preterm contractions is higher later in the gestation. Okay, intraperitoneal operations and disease process with intraperitoneal inflammation Okay, intraperitoneal, and whatever the condition, if it causes peritonitis, especially in the third trimester, there is increased risk of preterm labor. So these are the choices of prophylactic tocolytics. If it is before 32 weeks, then you'll go for indomethacin. Okay, terbutaline, magnesium, and indomethacin are effective tocolytics, of which if the fetal age is less than 32 weeks, we use indomethacin. Okay, if it is beyond 32 weeks, we will use terbutaline. Terbutaline is the first line of treatment beyond 32 weeks of gestation. This this slide shows some intra-abdominal pathologies. Okay, there are obstetric pathologies and non-obstetric pathologies related to uterus and parauterine organs or non-obstetric causes. Okay, some obstetric causes are ectopic pregnancy and HELP. Do you know what is HELP syndrome? What are the components of HELP syndrome? HELP syndrome will not occur at the same severity in every patient. Okay, it is a spectrum disease. HELP syndrome is a spectrum disease. It can have only liver manifestations or have all the manifestations, that is all the three manifestations: hemolysis, increased liver enzymes, and low platelets. All the three can happen, or only liver enzymes, or only increase in liver enzymes might happen. Okay, these are the various surgical conditions which are based on their anatomical location. On what are the surgical pathologies of the right upper quadrant related to liver, bile tract, and as you come into the right flank, there may be ureteric pathology, kidney pathology, and as you come lower into the right lower quadrant, pathologies are mainly related to the pelvic organs and cecum or appendix. Okay, on the left side, it is obvious all the anatomical organs which are present on the left side: the spleen or gastritis and gastric ulcers, and the midline pancreatitis. Diffuse pain is caused by small bowel obstruction or early in the acute appendicitis. Okay, diffuse pain and localized pain. Diffused pain is caused by obstruction of the small bowel, or early cases of acute appendicitis when peritoneum is not involved, when only the appendix is involved and the peritoneum is not yet involved. The pain will be diffuse, but once the peritoneum is irritated, you can localize the pain. You can localize peritoneal pain better, but you cannot localize visceral pain. Okay, so just like small bowel obstruction, during the early phases of acute appendicitis, you will get diffuse abdominal pain. You cannot localize the appendicular pain unless it involves the peritoneum. And also in pregnancy, you should be careful about the right lower quadrant pains and right upper quadrant pains, because as the gestational age grows, cecum and appendix are pushed a little bit higher. The growing gravid uterus will push the cecum a little bit higher and cause the flank or upper abdominal pain. You might confuse with polycystitis or some other causes in the flank and acute and right upper quadrant, while it may be acute appendicitis. What is the cause for different location of the appendix in pregnancy? Because of pushing of the visceral structures by the growing gravid uterus. Are you listening? Your messages are not being seen. Are you messaging anywhere? Okay. These are the pathologies in flank. What are the pathologies that might present with flank pain? Hydronephrosis, pyelonephritis, and acute appendicitis in late pregnancy. Okay, diffuse abdominal pain, as earlier discussed, might be caused secondary to acute appendicitis in its early stages or small bowel obstruction. Some other medical conditions, these two are not surgical conditions. These two are medical conditions which cause abdominal pain and might mimic a surgical pathology, but the cause is medical, and such conditions are acute intermittent porphyria and sickle cell crisis. Coming to laparoscopy and laparotomy, which is the surgical method of choice. Laparoscopy has the advantage of better visualization. Laparoscopy has the advantage of better visualization, while laparotomy will have more wound complications. But because of the side effects of pneumoperitoneum causing increased intra-abdominal pressure, in laparoscopy, you don't open the abdomen, but you insufflate air. This will cause increased intra-abdominal pressure, and this pressure will transmit onto the aorta and superior vena cava. Because in pregnancy, already there is a gravid uterus having its compressive effects on the aorta and IVC. Laparoscopy or pneumoperitoneum may cause even more increased intra-abdominal pressure. So in that way, if you think, it is better to go for a laparotomy. But visualization in laparoscopy is better compared to laparotomy, because even though there is a gravid uterus, it is better to navigate through a scope rather than through a laparotomy incision. Based on that and the experience of the surgeon, he will choose whether to go for a laparotomy or a laparoscopy in an acute condition, because experience also matters. Because a surgeon should be exposed prior to such conditions for emergency operations. How do you evaluate breast masses, and what are the causes of breast masses in a pregnant mother? Because of the hormones of progesterone and estrogen, there will be breast engorgement. Okay, increased increased S9, because even because of the increased S9, if there is a breast mass, if you take an FNAC, you will get hypercellular material. It may be a normal physiological breast or a neoplasm. You cannot differentiate between a neoplasm and a pregnant breast by doing fine needle aspiration. So fine needle aspiration is contraindicated or useless. You have to go for core needle biopsy. What is core needle biopsy? Biopsy with a thick needle, okay, with a wide. Hello. Oh, no. Okay. ఓకే ఓకే నేను ఒక క్లాస్లో ఉన్నాను, కొంతసేపు అయి చేయనా? సరే, ఓకే, నేను ఒక 20 minutes ఆగి చేస్తాను. So of these breast masses, there can be non-malignant conditions, infectious conditions. Galactosils. Galactosil is neither an infection nor a neoplasm. Galactosil is an infection because of the blocked lactiferous duct. Because when a lactiferous duct is blocked, milk will accumulate in the lactiferous duct, and that is called galactosil. Okay. Mastitis is more common in pregnancy. Abscesses might be the cause of breast masses. lipomas, fibroadenomas, hyperplasia, and adenomas. If a breast mass is persisting for more than 4 weeks, then you have to evaluate it. What is the evaluation of choice? Not mammography. As we have already discussed, mammography has ionizing radiation, so ultrasonography is the investigation of choice. And rather than fine needle aspiration, core needle biopsy is advised. After ultrasonography, even if it doesn't help, MRI is better than mammography. This is the algorithm showing the evaluation of breast masses, okay, that persist for more than 4 weeks, especially in pregnant patients. What are the hepatobiliary diseases happening in pregnancies? Acute cholecystitis is common, okay? Acute cholecystitis is common, and unless there are some stone pathology, you can treat with antibiotics. But if there is any stone pathology, or if the stones trickle down the biliary tract, they may also cause pancreatitis. Gallstones, if they trickle down through the common bile duct and impact at the ampulla, it will also block the pancreatic duct and it will cause pancreatitis. So if there is any stone disease in the hepatobiliary condition, then you will treat it surgically. Otherwise, cholecystitis with no evidence of stones can be treated conservatively with antibiotics. Okay, the timing of cholecystectomy. If it is a benign condition, as we already discussed, if there is no stone disease, you can even delay it. You can treat it with conservatively with antibiotics and postpone cholecystectomy to some around 6 weeks after pregnancy. By 6 weeks after pregnancy, the pregnant mother will return to the pre-pregnancy physiological status, and hence all elective surgeries, if they are not having any immediate deleterious effect, you need to postpone them for 6 weeks after pregnancy. You need to postpone them for 6 weeks after pregnancy. But if it is an acute condition and if it compromises the health of the mother or the fetus, then you go for immediate surgery. And laparoscopy or laparotomy is a choice based on experience and its specific conditions. Though acute appendicitis and acute cholecystitis can be safely managed, lap cholecystectomy and lap appendicectomy can be safely done in pregnancy throughout all the 3 trimesters. Okay, throughout all the trimesters, lap cholecystectomy and lap appendicectomy can be done, but because of the variable position of the appendix, some prefer going for open method or some prefer going for hybrid method. They see the position of the appendix through a laparoscope and give the incision at the correct place wherever the appendix base is located. Okay, the incision is given not at the regular McBurney's position, but after visualizing and localizing the base of the appendix through ultrasound or through a laparoscope. Then the incision is given at the level of the appendix base. Okay, what are the endocrine problems in pregnancy? What are thyroid problems are more common, and among hypothyroidism and hyperthyroidism, hypothyroidism is more common. How do you treat hypothyroidism, and what are the doses of thyroxine to be used? Treatment of hypothyroidism is based on TSH values. Treatment of hypothyroidism in pregnancy is based on TSH values. You have to maintain a TSH value less than 2.5 milliunits. Okay, you have to maintain a TSH value less than 2.5 milliunits per liter. So you can start at a starting dose of 1.2 microgram, and if TSH is between 4, this is if the TSH is less than 4.2 in the first test. If it is between 4.2 and 10, you will increase the dose of thyroxine to 2.4 microgram per kg. If it is beyond 10, you will 1.2 is the dose for TSH less than 4.2. 1.4 mics per kg per day is the recommended thyroxine dosage for TSH between 4.2 to 10, and 2.4 is for TSH values above 10. What is the goal? What is the TSH goal during pregnancy? It should be less than 2.5. What does thyroxine do during pregnancy? It is very crucial for the organogenesis and fetal growth. If there is no thyroxine, or if the pregnant mother is subjected to hypothyroidism, there will be IUGR. There will be decreased birth weight, or there may also be congenital abnormalities. Organogenesis might fail, or the baby may not thrive enough. So gestational thyrotoxicosis, this is also hyperthyroidism, and you will treat hyperthyroidism with thionamides in pregnancy. Propylthiouracil and methimazole are safe in pregnancy, and they are used. And what are the doses of methimazole and propylthiouracil? Dose of methimazole is 15 to 100 grams per day. 15 to 100 grams per day is the dose of methimazole. 300 to 1200 grams per day is the dose of propylthiouracil, and a beta adrenergic agent is also used. But radioactive iodine should not be used because of ionizing radiation, which might cause teratogenic effects, and ulcerative colitis and Crohn's disease. Crohn's disease is much severe, and because of the opposing rectum and vagina or cervix, Crohn's disease is much severe in pregnancy. If it happens to recur, then it will have very gross deleterious effects, causing fistula between the ripe vagina or cervix in the rectum. So Crohn's disease might sometimes need surgical intervention. We use omentum in case a Crohn's disease is going for a surgery in pregnancy. We try to place omentum in between the repaired rectum or the excised bowel and the uterus to prevent any fistula formation at a later stage during the healing. How can you use omentum in Crohn's? Omentum can be used as a interposition graft. Omentum can be used as an interposition graft in between the gastrointestinal tract and genitourinary tract, or the uterovaginal complex. What is pseudo obstruction? Constipation is common among females, among pregnants. And why is it common? Because of the pressure effects. Most of the conditions or most of the changes are because of the pressure effects of the gravid uterus. Okay. Apart from this constipation, there is another another obstruction called as pseudo obstruction, wherein there will not be pathology extramurally or intramurally. There is no anatomical pathology at all. Anatomically, the lumen of the colon is intact and normal, but yet it fails to have a functional peristalsis. Because of failure of peristalsis, it mimics an obstruction. This is called as Ogilvie syndrome, and the treatment is with neostigmine. Okay. Treatment of Ogilvie syndrome or colonic pseudo obstruction is with neostigmine, and during immediate resuscitative measures, we can do colonoscopic or flatus tube decompression. We can decompress the distended colon by colonoscopy method or through a plain flatus tube. Colon cancers, these are very rare, but vascular pathology is common. Okay. Thrombosis is more common in pregnancy. Why is thrombosis more common in pregnancy? Thrombosis is more common because of the estrogenic effects on procoagulants. pregnant females have uh, high serum levels of procoagulants, and even among females, pregnancy is even a more procoagulant state, okay, or hypercoagulable state. Because of that, patient should be pregnant mother should be continuously ambulated, okay. They should not be allowed to sleep or sit idle for a long time, because in addition to decreased venous return and compression on the IVC, the blood flow will be slow, and in combination with that, the blood is hypercoagulable. So this can cause increased thrombosis or DVT in the legs, okay. As I said, the CT scans are used only if necessary. Ultrasound should be the first imaging modality, followed by judicial use of X-rays and CT scans. Okay. CT scan should be considered if there are no other modalities to diagnose the pathological condition. So, during the surgery, we have to monitor the fetus, because during early stages of hypotension, the mother even might not have any tachycardia. The mother even might not have any tachycardia, but there will be fetal compromise. The early sign of hypotension is fetal compromise. Okay, so fetus should be continuously monitored during general anesthesia and during surgery or blood loss or trauma, to ensure that both mother and fetus are fit. Mother does not show signs early, fetus shows early signs of hypotension. Okay. To summarize, pregnant patients are susceptible to same surgical diseases as like non-pregnant patients of the same age. Maternal physiological changes of the gravid uterus should, and other factors like procoagulant factors, change in GFR, change in endocrine status, all these should be kept in mind while dealing with the surgical disease. And this shows that laparoscopy is being used for many conditions. Okay. Any questions? Someone is talking, but I am unable to hear.
No, sir.
Yeah, no, no doubt, sir. Okay, then can we end the session?
Yes, sir.
Okay.